So I would love to get started. Can we take down the slide and have our panelists turn on their cameras? So good afternoon. I am just so excited about to be able to moderate this session. My name is Cindy Brock. I'm with the Agency for Healthcare Research and Quality, and that is part of the U.S. Department of Health and Human Services, which is known by the acronym HHS. I co-lead the HHS Health Literacy Work Group, as well as health literacy activities at HARC. And with me today are 5 individuals who are health literacy leaders in their healthcare organizations. These are people who have my profound respect as they are in the trenches, leading the charge to actually make health literacy improvements. So these are the people who I'm assuming that you are doing your research for, that I'm going to go out on a limb and suggest that everybody who's tuned into this session is working towards a goal of improving organizational health literacy, that we all share a common plan to try and make things easier for people to find, understand, and use health information and healthcare services. And so the individuals who you see in front of you are actually doing this work. So I will introduce them. This is my least favorite part of moderating a panel because I always trip over my words. But first I will introduce, I'm doing it by alphabetical first name order, in case you were wondering. So first is Dr. Carolyn Cutalini, and she is a patient education specialist at Penn Medicine, spearheading initiatives at the unit through the corporate levels. Her scholarly works include research on sources of health information used by older adults, co-chair of the Healthcare Education Association's Patient Education Guidelines, grants for health literacy and health communication projects, multiple publications, and national and international presentations. We also have with us Greg O'Neill, and as Director of Patient and Family Health Education, Greg leads the strategic plan for patient education and health literacy initiatives at Christiana Care. After moving on from direct patient care as a trauma surgical ICU nurse, he developed a team of nursing professional development specialists who champion health literacy best practices, support all manner of patient education initiatives, and manage content vendor relationships. Also with us is Jane Sims. She's been working to build health literacy in Utah through innovative communication for health professionals, their patients, and the public at large for more than 25 years. She currently serves as Patient Education Manager for Intermountain Healthcare and Coordinator for the organization's Patient Education Guidance Council. And we have with us Karen Commander, who is Director of Organizational Development and Health Literacy Institute at St. Vincent's Charity Medical Center in Cleveland, Ohio, where she's led health literacy initiatives since 2007. She is also co-founder and immediate past president of Ohio Health Literacy Partners, a statewide nonprofit health literacy collaborative since 2013. And is most recently chair of the National Council to Improve Patient Safety Through Health Literacy. And finally, we have Tom Bauer. He is the Senior Director of Patient and Family Education at Johns Hopkins Health System. And he has dedicated the last 16 years of his career to investigating and implementing the best practice of health literacy. And how does he know what that best practice is? Well, he started coming to the HARC at least a decade ago. So that is what we're going to be talking about. I'll share with you the format of our session. we are going to tackle 4 questions. The panelists, 2 or 3, are going to respond to each of these questions about how they use research, what research would be useful to them, and help give you some insights that hopefully you can use in developing your next project or shaping your current one. We will then be able to engage in the discussion. So this session is in a webinar format, which means you guys are all muted and you can't unmute yourselves. However, when we get to that discussion part, you can hit that raise hand in the bottom of, well, for me anyway, on the bottom of your Zoom menu. And you will be unmuted and we will be able to hear you. So, so I'm going to launch into that first question, but I also want to acknowledge the expertise of all of those who are attending, whether it's in research or direct services. And so please, we will not think it's rude if you chat your own answers into the chat. I'm going to try and I'm going to ask you, but I know it's really hard. It's very confusing. You have the chat and you have the Q&A. If you could try and put in the Q&A actual questions that you would like to ask the panelists, that would be great. And in addition, remember, you can unmute yourself at the end. But during, I know in the sessions I've attended today, I needed to put my questions in right away because I knew I would forget them by the time the Q&A part of the session started. So feel free to just, put those down. It doesn't mean you can't unmute yourself as well, but we may also respond to them in writing, and then chat amongst yourselves, or, answer questions, share resources. Don't be shy about fully engaging here. So let us turn to our first question. Our first question is, what health literacy research have you used in your work? So we're going to start off with Tom. Tom, how have you used the research that has been produced around health literacy?
What I've done is I've taken the research that I've found and shared it with senior executives and other people that are passionate about health literacy. So when we began our work when I was at Novant Health, there was a group that was created that really looked at how do we embrace health literacy as an organization. And then from that, we used the research to demonstrate what it was, the impacts could be, and then taking a look at the problems that we were trying to solve or the opportunities we were trying to meet, and looking at those and trying to make a match. And so it really was designed to create awareness, to understand the impact, and understand the prevalence of low health literacy. So really, it was in that initial stages that helped us to launch. And then what we wound up doing is we started creating some of our own research to show the impact within the organization itself. And what I've learned is that the initial research helps to create the awareness, and then showing that it happens at home stimulates the growth.
Okay, so that's terrific. So you're using it for education, you're using it for building a case. And I'm going to warn my panelists, I'm going to probe you a little bit more to see if you could come up with a specific example of a research study that you then took into practice. And now I'm going to see if Carolyn would like to add or contradict. What do you want to add to the discussion? How do you use research?
I think we've used, and maybe not directly a research study, but the accumulation of research studies. We have a tendency to use guidelines that have been built upon a consensus. For example, the AHRQ toolkit for health literacy with the PMAT in it, and that has the one for materials and the other one for the audiovisual. So we know that that is accumulation of a lot of research that's been done. The same thing with the CDC CLEAR Index, Clear Communication Index. When it comes to specific research articles, lots of times we will go that direction if we're looking at a particularly challenging topic or any topic. that a group has come to and asked, how do we best approach this? I can tell you, as being co-chair of the HCA guidelines, under Teach Back, we have numerous articles that are there that have shown the benefit of Teach Back through research. So those are some of the specific ways that we have used research in our organization. We do look for opportunities to then maybe not necessarily do research within our organization, not that we don't want to, it's just may not call for it, but at least QI projects where we use the information that's already known, because the difference between QI and research is, taking something that's already known and applying it to your organization is a little bit more QI than necessarily research. So we do have a tendency to use research in the QI process when we want to improve things for our patients.
So, so you made a really interesting point, which is that, while you may not implement, the exact thing that was studied in some intervention in some study, it's the sort of synthesis of what is learned, and two, the tools that have been developed that are evidence-based. So that evidence, that research is allowing the development of things that you in the healthcare system can then take and use. I love
Absolutely. And one of the ones I didn't mention, but used for years and still do, even though it's older, is the Suitability Assessment of Materials by Dok and Root. Still to this day, that book sits on my shelf and I refer back to it because it is a good tool that does look at things slightly differently and has a couple different angles on it. So it's a combination. We use specific research for specific topics, but we have a tendency to use guidelines or things that accumulate research to guide overall processes.
That's great. And I'm also fiddling here, trying to grab the resources that you guys are mentioning, but feel free to, type in the chat, anything that you think would be of interest to the audience. I'm going to turn to Jane now, but remember, I'm going to come back and sort of ask you now, I guess, Carolyn, you had mentioned specifically Teach Back, but, if there's any types of studies or any particular topics or something where you said, yeah, here's an example where we took this research and this is what we did with it, because I think they'd be really interested in hearing those stories too. So Jane, how do you do it in Intermountain? How do you use that research?
Well, I first would like to kind of second what Tom and Carolyn said, in that, we tend to rely on the guidelines. And I think of the HCEA guidelines, in which Carolyn was instrumental in developing as an example, and use that kind of as the base. But if you want to get specific, I think about the Plato design principles that were developed by the IHA. And we have used those extensively in the development of our custom content. And then we also like to kind of take that human-centered design approach, in that we utilize a lot of focus groups and caregiver surveys. When I say caregiver surveys, caregivers are what we call all of our Intermountain healthcare staff, clinical or otherwise. And so we take that research, we apply it in our processes, and then look at what's best for the patient. Some specific items I would say, the Plato design principles, the Communicate Health has put out quite a few things, and I'm thinking of one green paper in particular. It said, when it comes to health info, plain language is not enough. And that's kind of one of my guiding principles when working with the Patient Education Guidance Council. We talk a lot about plain language, and we've done some training with physicians on plain language, but I like to remind them that it's not enough, that we really need to look at that patient experience and focus our work on that, as opposed to just looking at plain language work.
So Jane, not everybody is going to be familiar with the Plato reference. So could you explain a little bit more in our interest of clear communication, how that works?
So Plato stands for the Plain Language Assessment Tool, and it provides a set of principles for writing and design of patient education materials, like font size and white space, even font choices, using illustrations, even going into some multimedia design. And, it's based on the ability to provide the cleanest possible information. So I was attending a session earlier today on consent forms and looking at how they have revised those consent materials using visuals and plain language. And that's a really good example of how you would take a really dense document and sift it down into a few key sentences with some illustrations or pictures to tell the story, to help the patient really understand what's happening in the moment.
And you also mentioned human-centered design, which is the idea of, involving your target audience or the people who are actually going to use what you're doing and crafting it. And is that something that you look for when these evidence-based tools? Is that a hallmark, of a tool that you might want to use, or is that something that you just do to customize things, to adapt them to your own setting? How does that play out?
Absolutely. I'm always looking for research in that field, because I believe that we have created our best work when we follow those principles. And so I'm looking for ways to apply that into different service lines or topic areas. What we might do for joint replacement might be different from what we do in behavioral health. And so I'm looking at how those principles are applied across a variety of topics and service areas.
So I just want to check back in quickly with Carolyn or Tom to see if you had any anecdote that you wanted to share. Otherwise, I'll move on to our next question.
I had a couple things. One of the things I would tell you is that when I took my new position now 7 years ago, one of the questions was, how do we strategic plan? What are your priorities? And I went to several resources. The first was the 10 attributes of a health literate organization. So as we developed our strategic plan, looking at evidence-based, we used that. Then I used the PMAT as my resource for materials creation as we evaluate. And I'll tell you, the value of something like a PMAT is very helpful when you have something that someone created outside of your department, and they bring it to you for review. And it gives you a nice tool that you can share with them to give the basis of your information. It gives you that resource, particularly in research-based organizations. And I found that those two tools to be extremely helpful in our development. And then the last is the 10 attributes of the or not 10 attributes, but the health literacy toolkit, Universal Precautions Health Literacy Toolkit. And those have really been, when I look at it, the three basic documents or pieces of published materials that have guided and influenced our work over time. And that I find those to be very helpful, not only in developing the work that we do, but developing the team that we have, and then developing the knowledge of those around us. Because part of our role is to spread this knowledge to others. So it's just not a department or a person, but is a movement within an organization.
Fantastic. I'm going to move on, but one of the things that I'd be interested in hearing down the line, if people want to comment on, is, when we talk about tools, how important is it that, all the research is cited in the tool so that you really know it's evidence-based, or does that make it too clunky and, bog it down with all these, references and stuff that, just thinking about how you use tools. Well, let me just open it up. Yeah, let you guys jump in there.
I was going to say, because that's one of the things that we had a challenge with the guidelines when we wrote them from HCEA is how do we incorporate the references in without bogging down the tool. And we made the decision that we would talk about a section such as teach back, and you would ask about something specifically we use. Well, there was a research article project done by Griffin et al. It was the impact of teach back on comprehension of discharge instruction among emergency patients with limited health literacy, a randomized control study. So what we did is when we listed teach back as one of the steps and we gave examples, we put this in the reference list. So it didn't clutter it up. Yes, do we not have maybe a direct relationship, but it is under the topic. So that is how we addressed it. And the other part too, through our guidelines, what we felt was missing with the patient ed process is that full assessment, planning, implementation, evaluation. One of the disadvantages of the PMAT and some of the other ones is, as Jane was alluding to, is it doesn't get to that patient-centeredness. It doesn't involve that part of it, where if you go through the assessment, planning, implementation, evaluation, it does. So we've taken what we developed at HCA. There were several Penn staff members who were involved in that. We've taken it and put it into our own toolkit, and we use it for all our consultation and assessments.
That's great. All right, I'm going to move us to the next question because I'm doing a lousy job of timekeeping. So what research would help you do your job? And we're going to let Karen kick that one off.
Okay, thank you. I'm very excited to have the opportunity to ask for what we need from all of you that are here. As was mentioned, I've been doing this work for a long time. And as we go along with the work, we find that I hit barriers, and I was very excited to see the new definition for health literacy come out with Healthy People 2030, which gives the definition of organizational health literacy. Because for a long time now, I struggled with putting all the onus on the patient. We know how complex this healthcare system is. And at the organization where I work, what I've had to do was to build the case and show why our organization has to be health literate. So I think that what I'm looking for is research that gives more up-to-date evidence on health literacy. You can get a better return on investment if you institute health literacy interventions as it relates to costs or patient readmissions. So more specific data around that. Because recently, like I said, I've been doing this for a long time, but if there's a change in senior leadership, then things change. We probably 2 years ago had a new president and CEO step in that really knew nothing about health literacy. So basically I had to come up with a plan on how to, introduce health literacy, do that 30-second elevator pitch with her, then set up an appointment. But what was important was having data to show her, why we're doing these interventions. So I think more up to date. The last data I knew about the financial aspect, as far as I know, was from 2007 Vernon report. So I think having updated report on that would be extremely helpful.
Terrific. Greg, why don't we get your input on this question?
Thanks, guys. Cindy, thanks for calling us out on jargon. I mean, that couldn't be more appropriate for a panel like this. So
Right.
We're all on notice for that. When I was thinking about this issue, to me, it comes down to scale, because I feel like we have 10, 20 years worth of evidence and recommendations from a lot of outstanding organizations saying what we should be doing. But I think we need some more research to tell us how exactly to do it, and then what
Mhm.
works. And the reason I say that is if you ask me, what kind of research do I need to do my job? I need more resources, right? Like everyone, I need more data. I need better interoperability. I need, especially, when it comes to EHRs, there's that jargon. So the electronic health record, and all the tech vendors that we're all confronted with on a day-to-day basis now. And certainly the revenue side, which either means cost reduction or improved incentives on all sides. So any research that can shine a light on that, on any of those kinds of issues to help teams like ours garner more resources and more priority in our systems is going to be valuable. And to me, that's especially if it's at scale, because there's a fair amount of research, probably more than there ever has been, around health literacy now. But I find a lot of it is pretty specific. This particular condition in this particular environment with this particular intervention. And for folks like us who are kind of charged with changing the culture in an entire health system, we need things that can be done at large scale, right? So any research around our initiatives for implementing best practices. For instance, we have a Teach Back initiative here. It would be great to be able to demonstrate and show that a widespread initiative across the health system can have the same impact on health outcomes that we're looking to have, the same impact on patient experience metrics that everyone's tracking, and maybe even some cost and revenue stuff along the way. So those are the kinds of things that I think would be very helpful. If you would like more specifics, I have some other ideas I can share with you, but
Yeah,
I'll leave it there.
I actually would, because I mean, I totally hear you, which is, like Teach Back, it doesn't matter what condition, what population, you can use it across the board. And those kinds of interventions where, are broadly applicable, but are fantastic. But if I'm a researcher and I'm trying to put together an application for funding, I've got to be specific about what it is that, I'm going to look at. So, if you had to help that researcher narrow down what they could actually develop a study on, that would be great.
Yeah, I think at this point we've kind of made the case conceptually, and now we really need to make the case for decision makers in our systems, right? Because we're going to have to go back to the business side of the org, and the leaders in the organization, and say, here's the demonstration that when let's say you correlate what's happening in the EHR in terms of asset utilization. So if you're using patient ed content and you're documenting it over here, and there's no connection to the documentation or the patient journey around that education process to the assets that are being utilized, and then linking that to the patient outcome on the tail end. If you can't connect those dots, how are you going to make the case to your senior leadership that you need more resources, you need more investment? To me, it's kind of analogous to quality and safety, right? Over the past several decades, we've made major advances in quality and safety in healthcare. And we have health systems with giant teams doing a lot of support work and tracking and data analysis around quality and safety. There's as much to be gained, I think, in the field of health literacy. But in order to garner those resources and prioritization in the system, we're going to need some building blocks through the research. So to me, anything that kind of links to those key metrics of patient outcomes, experience, or revenue cost savings, and then if you can link it to the utilization of your assets via vendors or through the EHR or through custom content that we're talking about crafting today, I think we just need to get better at connecting the dots.
So I totally get it. I'm going to come back and push you a little bit more in a few points of that. One is that I worry about setting up studies for failure by trying to show a huge impact for a somewhat modest intervention, that we know that, there are a lot of factors going on. So thinking about, I really want, and I'm also going to point you, Greg, to the chat where somebody said that they were quite interested in, projects or ideas for nursing students, doctoral students, and faculty. So, there are people on this session who, if you had a really great idea that could be somebody's dissertation project, it could actually happen. So just think about that for a minute. And I'm going to circle back though to Karen to see if she wanted to try and throw out some kind of topical guidance. If you had that magic wand and could say, I want this research study, what would that be?
To echo Greg, I want research to connect the dots, but I think to be specific, for me, I think that we really need to get organizations, and specifically the C-suites, high-level executives on board. So I find it difficult to, like Greg said, get any of the resources that I need. For me in my department, it's me, but I have an institute that has about 12 other members, but it's on, their extra time. So I think having research that, again, shows why health literacy is so important. And I think, Greg, I want to echo what you said about how we have provided so many resources to quality and safety. But I agree that health literacy and safety, and I'm going to talk about this a little bit more in a bit, but how that's so critical, that it ties in completely health literacy and patient safety. So I'm going to go there in a minute.
All right, so we'll get onto that momentarily, but Greg, do you want to meet my challenge at all, or shall we move on?
Challenge accepted.
All right.
All right. So let's say right now, we all know that equity has really come up as an issue recently in healthcare. So specifically a project that looked at the preferred language for patients and families, and if content is being delivered in that preferred language, and then looking at the subsequent point in care, in seeing what the outcome was, or how it changed the utilization of a health system. That would be a key one nowadays to nail down. If we have a suite of offerings that has 20 different languages, but no one's using it, then that is not money well spent. We're not, we need to make sure that the money we're investing in these systems is being utilized appropriately and actually reaching the end target. So that's one example.
That is great. Although I am going to have to penalize you for using the word utilize, because
well,
I just tease you.
I agree with you on that one. Yeah.
But this is a perfect example, and it actually is sort of echoing what the opening plenary speaker talked about, which is a strategy that I have called catch the moving train, which is, she said, cancer is a big deal in my organization. I bet I can get money for, cancer screening project. Or the second example she gave was COVID. Okay. Everybody wants to figure out COVID. And you've just mentioned health equity. That is a huge priority in the Department of Health and Human Services and in healthcare organizations around, and funders. And so, yes, I get a big check for that idea. And I'm going to acknowledge people who have written questions in the chat, urge the panelists to take a look, because we will be getting to that portion of this session soon. My next question is, what research does the field need to make the case for health literate organizations and increase the spread of health literacy strategies? So this is maybe a slight twist on the earlier questions about, like, what would be useful for you in your job, and really thinking more broadly. So we may hear some similar things, but we may hear some somewhat different things. So Tom, why don't you kick this one off?
I'm going to start in a different venue for a second.
Okay.
One of the things that I think about with health literacy is the joy of medicine. And what I have thought about here is that I believe that health literacy can bring more joy to healthcare practitioners when they do it well. And what I have seen is, and it's all anecdotal, I'd love to see the research. But what happens is I've talked to individuals who have used TeachBack, for example, and I asked them what their reaction to it was. And what I hear is that TeachBack can be very humbling because they learned that they've not been effective presenters over time or educators over time. But what I'm also hearing is that they see it as a challenge to become better. And as they become better, they're finding more joy in medicine. And so I would love to see research done that looks at not only cost, quality, and patient satisfaction, but also satisfaction from the healthcare professional. So I think that would be an area that I would encourage research.
That's beautiful. I mean, I'm actually working on a burnout tool right now with in my agency, and we've done joy in work training module. That is a fantastic topic, and I totally agree with you that if you actually get the gratification of knowing that somebody understood and was able to make a decision or take an action because you were clear and, or you made it easy to get the service they needed or whatever. I love that. All right. So I am, though, going to push you on to the sort of next piece of what does the field need to make the case for health literate organizations and spread the strategies.
Is that to me?
Yes. Well, or actually, yeah, why don't, since you just spoke, why don't we move to Carolyn and we'll loop back to you, Tom. Carolyn, you're on mute.
So to go along with what you were saying about the initial speaker this morning, I think one of the big things that the field needs is it's patient satisfaction, but to tie health literacy fully in with the patient experience, because that is a big wave going across the country now. So I think that is one of our opportunities.
So Carolyn, before you move off of that, in the chat, we had a question, I don't know if you saw, about specifically linking patient education to the patient experience. So just might want to embellish that a little bit.
Yeah. So, well, I'm just thinking about where to ride the wave. So to me, so where do we need help in the field? We need help in the field with anything that will tie together the patient experience, patient satisfaction. And obviously we talked about cost reduction. I mean, every time I go to do something, you're constantly asked, what's the return on the investment, whether it be a financial return on investment or even resources, effort, something along that lines. So when I think about the field, that is what I'm thinking about.
And so in the measures of patient experience, you're thinking about like the CAPS surveys of patient experience, where there are monetary incentives to get better scores. There are questions on those surveys that ask, how easy was it for you to understand your doctor, or do they respect and stuff. So maybe researchers using those measures in their study that would help you bring that back to
I think the other thing is episodes of care. Because episodes of care, once again, have financial things tied to them. But I think of the orthopedic field, tremendous amount of episodes of care that are being tied together, that a lot of it is patient education focused also.
Okay. Let's see, who should we pick on?
Can I add to that?
Yeah, can you hold on one second? I just want to see if Karen wants to jump in, and then we'll get.
Yes, I do want to jump in on this one. Along with patient experience, like I had alluded to, the patient safety aspect. And so I'm going to talk specifically about a project that several of us here on the panel were involved in. It was in 2019, there was the city of Cleveland has a health literacy committee. And a couple of people on that committee worked in some larger health organizations in the city and were extremely frustrated that they could not move any of their health literacy to a centralized interventions. And basically the topic came up that if it's not mandated, it's not getting done. So we decided to put a team together and write a proposal to the Joint Commission to elevate health literacy to a national patient safety goal. So we spent about a year on that, and that was the National Council's work. The response from the Joint Commission is that there was not enough research linking health literacy interventions with patient safety events. So I can see that as what we need in the field, specifically linking patient safety events. You know, like we mentioned, quality teams are assessing, you know, different sentinel events or any type of safety event. And I think that if we start looking at anything communication related, we could really use that research to move our efforts forward.
Right.
And one other thing is to look at research that will help implement different research strategies. We can have the research here, but if we don't have ways in which we're shown how to implement certain strategies, like I think, Greg, you alluded to on a larger scale, it makes it challenging.
Yeah, and there's a comment about implementation work in the chat. I want to get to that in a second, but Jane, you wanted to hop in.
I just, wanted just to add a little bit to what Carolyn and Karen had talked about in terms of attaching health literacy to the patient education experience. And one of the things that someone is working on in our organization in the Office of Patient Experience is a diagnostic error evaluation and research taxonomy. It's kind of a modified taxonomy, and have added communication questions to that research that they're doing. So how well did the physician talk to the patient? Was teach-back engaged? Some of these other questions that we're trying to understand so that we can better understand the outcome of the patient in relation to what happened in that one-on-one experience with the patient and the caregiver. So there are ways to do it, and this is something that we're really looking at internally and how we can learn more in that.
And Tom, did you want to hop in, or shall I kind of pick up on Carol Howe's comment?
I go ahead and pick up with follow-up.
Great. So Carol, who's a researcher down in Texas, says, she thinks we need more implementation studies. And I'm hearing sort of, you guys have been talking around that a little bit and maybe the word a couple of times, but she puts out, sort of a hypothesis that basically providers don't care about randomized clinical trials, that they don't need that, gold standard, and I'll put that in quotes, kind of research in order to make decisions about whether or not to adopt a strategy or a kind of intervention. Does that resonate with you guys, or do you? Because I also hear, oh no, doctors, they want to know the actual number to treat statistics and all of that sort of stuff. Yeah. So okay, who wants to jump in on that? Yeah, go ahead, Greg. You go.
I actually wanted to talk about that, so I'm glad it came up. I think there's two different audiences there, even when we're talking about providers, because you have provider leaders who are going to be really looking at those operational gains from those kinds of studies in terms of, to me, that goes back to the cost reduction side if you're going to make something highly efficient because of a process improvement. And then you have the sort of direct care folks who are a little bit more, in my experience, looking for that evidence of like, if I take on this new practice and weave this into how I care for people, is it going to actually improve the outcome that I'm looking for? So I think those folks are in my opinion, still looking for that that more robust study to show that in their field this works. So I think you might have both on that.
Great. Anyone else want to jump in on the implementation study versus randomized controlled trial?
I'll just jump in real quickly. I agree. I think that we want to see outcomes primarily. Are our interventions improving outcomes? And in our organization, we did a teach back study on looking at the use of teach back, patients' acknowledgement of the use of teach back, but that was like a discharge. And I'd like to see a research that would look at patients acknowledging teach back post-discharge and what the outcomes look like as far as self-care and following discharge instructions.
But I guess my question is, what is the level of evidence or the rigorousness of the study in terms of are your leadership going to only be convinced if we randomly assigned patients and made sure that they controlled for any differences in the baseline and did that in an extremely rigorous, or would it be sufficient to take advantage of a natural experiment where one clinic was doing something differently than another clinic and seeing what the differences were there? So
yeah, from our standpoint, yes. Initiating a small study in one clinic and scaling it to another clinic, or comparing outcomes at two where one was implemented and another was not. Those are things that our organization looks at and would be willing to do more of. Yeah.
Tom, I'm going to put you on the hot seat, and I'm allowing myself to do that since my husband is a professor at Johns Hopkins. But the reputation you guys have is being, rather snooty about the rigorous nature. Is that really a myth, or do you think that people really prefer, or at least value, I shouldn't say prefer, research that is grounded but a little less scientific method?
It was funny that you called me out on that, because I was thinking about how I wanted to comment on that.
Sorry, you can pass.
No, you're absolutely fine. I came from a community-based health system in my initial work, and now at Johns Hopkins. And I would tell you that I think some of this is situational. I do think that the higher rigors of research are in a research institution tends to be a little bit more expected. I think some of it comes a little bit more relaxed in a community setting, but that is also situational. So I don't know that you can generally state something in that regard, but I think it's situational, but probably more so in a research organization like Hopkins.
Yeah. Now, Carolyn, you're at Penn Medicine. That's a pretty highfalutin research organization.
Obviously, the higher the level of evidence, if you look at Melnick scale or whatever you're looking at, is still held. Although I think, when you do qualitative studies, you're really getting different information than when you're doing randomized control. I think the advantage of a higher rigor, if you can even do it, is trying to tease out what made the difference, because you said there are so many factors here. I'll relay it to another part of my life. I did mortality review for a number of years. And we really had a hard time teasing out what improved our mortality because there were so many things going on. There were sepsis bundles and all this. And patient ed kind of falls in the same situation, is there are just so many factors. So I'm not sure how rigorous we can get studies to be, whether we can control every part of this to get to that point. So I think that will almost dictate to an extent what you can do. But at the same time, you don't say we don't do anything just because you can't control everything. But then you recognize that, and,
Right.
and it goes with your limitations.
And I want to, I'm actually going to slap my own hand here because, Carol points out that, implementation studies can be plenty rigorous. So that's not the word that I should be using when I'm talking about this. And I say that all the time about qualitative work. Qualitative work can be done very rigorously and yields a different kind of knowing and type of information that you just can't get with a randomized controlled trial. All right, any other thoughts before I proceed to the next question? Tom, I didn't know whether you actually got a chance, because I just sort of grilled you to opine on what the field needs, or have you gotten it out there?
I've gotten out what I need to say.
Okay, great. So with that, I'm going to ask my last question, and then we will get into more of this chat. And don't forget, guys, in the Q&A, you can put direct questions, and we can also unmute you. So how can researchers collaborate with your health systems? So, we've got an opportunity here, and somebody sort of was almost asking, hey, what about, nursing faculty and doctoral students and stuff. So somebody is participating in the session and said, gosh, I'm a researcher. I would really like to do some implementation work in the real world. And, can we do something together maybe? And I am going to start with Jane on that one.
All right, this is a great question. The key, I think, for Intermountain is, to have an appropriate grant-funded research or opportunity, from a large organization like HARC or NINR, or even other hospital systems. We partner with them on research projects all the time. We're willing to be a primary or a co-investigator, but we're looking for sponsors that support our vision and mission. And the right study, the right partner. We're very enthusiastic. We take part in. We're involved in a lot of different research, national research, so a lot of these processes or projects that are ongoing right now involve some level of health literacy need. And I've done a lot of work with our teams in developing their education content and reviewing it before they go to the IRB and go live with their product. And so there's opportunities there. Just looking at Intermountain overall and our geographical footprint, Utah, we're one of the top urban states. 90% of the population live in an urban area, but we also have rural and frontier populations. So there's the opportunity to look at different perspectives. In Utah, we have one of the healthiest older populations. But next door in Nevada, which is also part of Intermountain Healthcare, we have one of the unhealthiest older populations in the country. So again, there's opportunity. Roughly 22% of our service area speaks Spanish. And we have a really large geographic area, in that we're in Utah, Nevada, Southern Idaho, Colorado, Montana, Wyoming, and Kansas. So you're getting a lot of broad perspectives, as a researcher, if you want to partner with us. And we also have strong affiliations with all of our regional universities. But I think, come to us with a solid project, then we, working with me and our nursing director and our IRB, we can get things going. It's just, we just want to make sure that the project meets our vision, mission, and goals.
Right. So I'm going to ask you about the nitty gritty. So let's say I have an idea. I want to work with you on the application before I submit for funding. How would I go about doing that?
Yeah, just you can reach out to me directly, or and I can put you in touch with our nursing research director and anybody else who might be relevant to that. We are actually going through this process right now with our Salt Lake County Health Department on a health literacy initiative. And so we're working with our medical group and primary care leadership to determine how we're going to work this into their workflow and which locations we're going to do the project, and what those outcomes are going to be. And so yeah, we're open and ready to engage with you.
That is great. So I took the liberty and put your email in the chat.
Thank you.
So Greg, what about Christiana Care? Again, they are located in Delaware, for those of you who aren't familiar with their operations.
Yeah, thank you. We have a pretty good sized footprint in Delaware. We also work in the whole region. So we have some care going on in Pennsylvania, Maryland, New Jersey as well. So there's opportunity here, and the answer is always yes. So that's the short answer. Go ahead and reach out. I just a couple weeks ago had our chief research officer forward me a request from a resident who had an idea, but the application was in a week. So we hopped on a call and we started hammering stuff out. And I think that's what it's going to take. So not going to say no to more help.
Okay. I do, though, want to say, Greg is not inviting you to plan to call him the week before it's due. It'd be better if he heard from you earlier.
That would be worst case scenario. But, given who emailed, I jumped and we got on it. So not going to say no to more help. I think, Jane really said it all, and I don't want to reiterate a lot of those points that make this possible. But, the funding piece is a part where, my team is busy doing sort of their quote unquote day job to drive practice in the system. And so anyone from externally who's going to help with some of that, the funding process, the data analytic process, maybe even data collection, and evaluation, all of that is just going to be seen as more help in trying to make the case. So we're willing to make the investment with some resource time on our end to collaborate. And that word collaboration, when I was thinking about this, that's really, I think, what it's going to take for all of us to make progress. Because when we have very large institutions, so to speak, that we're working within, like quality and safety and things that really drive the bottom line of healthcare, I think in order to compete and be at the table in those conversations, collaboration with all of our other interest groups is key. And the reason I say that is there's a question in the Q&A about collaborating with patient experience. So I will collaborate with anyone in the system who I think will help make the case. So it's the equity folks, it's the patient experience folks, it's particular IT groups that are working on technology advancements, your language services folks, your community education folks. So the collaboration is key. And so I would extend that to collaborating with anyone who's willing to help in the research space as well. And if
Right.
we can tie some of those things together, I think it might help us make the case.
So in that question, the phrase used was strategic collaboration. And I want to, see if anybody wants to focus on that. And Jane, it may have been before your time, it may still be going, but I remember when working with people at Intermountain that the patient experience people were used very strategically. First, using CAP scores to identify, centers, regions that sort of were, where there were some opportunities for improvement, and using that patient experience staff on the ground in those regions to then do the improvement work to address some of the health literacy issues. So I don't know if anybody, Tom, I know you've been patient experience, whether you want to speak to that or anybody else in terms of a strategic collaboration with patient experience between health literacy and patient experience.
Yeah, oh, go ahead, Tom.
Well,
No,
why
go
don't we
ahead.
do Jane and then we'll get to Tom.
Okay. Yeah, a lot of that work is still going on, and I work with those teams on a regular basis, and they say, we're lacking here, how can we improve our process? And so I walk through what their process is and how are you taking the patient into consideration? I know that these are your considerations. This is what you want to achieve as clinicians. Well, what is it that the patient needs to achieve when they come in here? And have you asked them that question? And that's what I always go back to them. Have you asked the patient what it is that they want from you or that they need from you? They oftentimes forget about that. And so I have, when they bring me in, I'm going in as an advocate for the patient and helping the caregiver understand what it is that the patient needs. And that could be simply taking a week to ask 10, 15, 20 patients a couple quick survey questions to help them really frame what their next step should be. And did I answer the question?
You absolutely did, and with great illustration. And my observation is that health literacy is sort of we talk about with healthy people, with health literacy being recognized as a foundational principle and an overarching goal, that to achieve patient or person-centered care, you have to address health literacy. And what you were describing also had echoes of goal-oriented care, where you start by asking people what matters to them, what are they trying to achieve, and they can't answer that if they don't understand, what the possibilities are and be able to assess the options that are given to them. So it's all, in my mind, very mixed up. And Tom, I hope I didn't just take your words away.
No, it was a perfect setup. And so what I would say is a couple things. My work 16 years ago was born out of patient experience. And that's where I got my initial root and my support. What I would share is that is a critical partner in which we've worked strongly together for years in validating our work and in supporting each other. But it's also important to remember that the collaboration has to occur in numerous areas like quality, like safety, like regulatory, and so forth, so that it has a broader, the folks understand it from a broader perspective. And so from the research perspective, understanding those impacts along the way in each of those areas is a critical component. And I also feel compelled to share another side to this that we don't often talk about, is that research that could help our strategic planners understand the importance of health literacy. Because if you look at the 10 attributes, one of the things that's important is getting senior leadership support. And some of that comes through the strategic plan. So being able to show research that impacts how you can strategically compete with other organizations or to form the strategy of the organization, why does that need to become an important initiative of the organization so that it is in the strategic plan itself? When you can get that level of support, it eases a lot, it brings with it a lot of support from senior leadership. And so that has been one of the keys to success for me in the last few years.
Fantastic. Okay, so I put in the chat, now is the time for audience members, if you want to be unmuted, to raise your hand. I know Helen Osborne had a question about disabilities. I don't know if you want to raise your hand or you want me to paraphrase you. We had Jeanette Helm and Thomas Coyle in the Q&A. So I don't think I can see it when somebody has raised their hand and is unmuted. So IHA, help me out here. Are you seeing any hands?
No.
I just turned on my participant list, but I'm only seeing us. Nope, can't see it.
I raised my hand, but I also am able to unmute myself,
Oh,
unfortunately.
you cheated. You cheated. This is Michael Pasha Orlo. If you don't recognize the, sorry, initials. Michael.
One of the things I think of as a challenge in large organizations for health literacy implementation has been maintenance of whatever the activity has been, maintenance. And so I don't know if this is a topic maybe hasn't quite come up. And is this something that you would want to see happen kind of on the research side, or is this something that you would aim to see as part of your operational activities, or somehow both?
Michael, I think you raise a good question, because what happens is, one of my great fears has always been as a leader of health literacy, is that if I were to leave or retire or whatever might happen, does that stop the work that we're doing? And what you're really talking about is, when you see gains, how do you sustain those gains over time and allow that to flourish and expand? And methods for that to happen, research would be welcomed to show that how to sustain the gains that you have, so that it is not just a core group of individuals, but how does it become organic to the organization?
Yeah, Greg?
If I can piggyback on that, I think that's one reason why it's really important for all of us to be advocating as much as we're working on all of this. Because when I think about the things that do have longevity, like you were saying, Tom, it's things that you have to do, right? So if you leave and no one picks up the banner, then that's it, right? Like all that effort kind of might wither. But if it's something that is mandated, or an expectation, or there's some reimbursement tied to it, the things that endure are because they have to, right?
I think one of the accelerators, you bring a great point, Greg. One of the accelerators is Leapfrog now has in its credentialing the requirement that informed consent, or one of the questions is about informed consent, and at the grade levels it's written at. That was a tremendous help to the work that we do. And those types of things, the things that Karen and I and others in the call are working on with the Joint Commission, are also things that helps us.
So Tom, I do want to point out, though, I've done a couple of town halls on the new standard on informed consent for Leapfrog, that it's not just the form, but they ask about doing teach back and the process, and a lot of great standards in there. So right now it's voluntary, but these are the kinds of things that drive change. So Nancy Morris, can you see if you are unmuted? Speak up. No, you still look.
Yes.
Ah, wonderful. Let's hear what you have to say. No, you're muted again.
Muted.
IHA, help her, help her. There we go.
Try
Nancy.
again.
Yes. perfect.
Okay. Okay, well, I wonder when we think about all of the interventions and your reference to carry through as participants change or employees change, how indeed we can get them to be built in. And unless it's a process of care, I think it will get lost. I don't know your thoughts about how to initiate these. So as many sort of templates and strategies that we can build in for use of our things that we use when communicating with patients just makes it more automatic. It's more likely to be continued because we know we're going to have turnover. We start over all the time as new employees walk through the door. And I wonder if you've seen any, or if that would be useful to you to have some templates, or I'm calling them templates, but structured things that this is the process which we use that would be beneficial for putting in place.
So you're talking about sort of onboarding and continual training?
Well, actually I wasn't, but that is, I mean, key, absolutely. You know, we all do those annual requirements, and there's a little bit about how to communicate to different age groups, at least where I'm employed, but not a real focus on health literacy components.
I can take that. So for St. Vincent's, where I'm at, we have it included in policy. So in our policies, our general patient education, family and patient education policy manual, we have requirements that we use plain language and teach back, that we train everybody on day one of onboarding during orientation. So we actually list out the requirements in our policies. And then we also do, like you just mentioned, Nancy, an annual. So annually during our online competencies, we do have a module on health literacy. So for me, as far as sustainability, we've done that every year. So it gets kind of ingrained in folks that, yes, we do plain language. Yes, we do teach back. And in addition to that, we do separate live trainings to keep that going every year.
That's great.
Anybody else want to chime in on this one?
Sure, I will. We have, in addition to policies, like Karen mentioned, standard operating procedures in my group, and we have them written out and templatized along with a reason why they need to be done and who kind of is the leader support for that. And so that if I, for some reason, can't make it to work tomorrow, those on my team know where to find those standard operating procedures. They would know how to onboard somebody else to do the work that I do because that information exists. And they would know who to contact, who else I work with in the system to do that work. So there are ways to sustain that, you know, as you go along. Mm-hmm.
Greg, did you want to hop in, or you?
I was just gonna double down on the policy front. So as much weight as it carries, we have a policy as well. And one of the great things about being on a panel with your mentors is if my policy looks anything like Jane's or Carolyn's, please don't say anything, because I got some advice. I got some advice on that front.
So I want to acknowledge some of the comments on topics. So there's, you know, there was some early interest when you guys were talking about sort of the return on investment, but also a recognition that that doesn't always just boil down to dollars and cents, that there are potentially returns of, you know, better patient functioning and you know, other kinds of benefits that health literacy strategies could reap. So just, you know, making clear that we are talking about the full spectrum. Another area of interest that a couple people have voiced is around health literacy and disability. So I didn't know whether that struck a chord with any of you guys on the panel. Yeah, Carolyn.
Actually, we've been talking about this a lot recently. One of the challenges disability, the term covers so many people with so many unique characteristics that fall into this category. So that's where we're kind of talking about now, because you have visual, you have hearing, you have, it could be orthopedic, it can be, dyslexia. It's just such a broad category. How do you narrow that down? How do you show it makes a difference? Do you pick a certain population? Is it a population that has a hearing deficit? So I can say that that is what our thinking now is, that yes, we'd like to look at that more, but because it is so broad, how do you do that? And we also feel as though if you get to know your patient, it actually does get addressed, because if you've done your good job with assessment, you know that this is an area where the patient needs extra support or help. So then you end up developing education that is very individualized for that patient. So I think it's even, you want to do something system-wide, but then again, you don't, because it's very individualized. So that is our current thinking.
So in the Q&A, we had a very specific question. What would you say to undergraduate public health students about health literacy and its relationship to their future careers? So, our conversation, you guys are all in health systems. We talk about healthcare, but, here's an opportunity to kind of broaden and put your public health hat on. Anything, that words of wisdom or provocative questions you want to pose?
Well, I already chimed in and said, I think it's critical. I don't think you can be in public health without not fully understanding the concept of health literacy, where it is, understanding healthy people 2030, population health. It is core to what you'll be doing.
I agree, and I do guest faculty work at CASE for the public health students, and I'll tell you, the feedback is amazing. Their eyes light up, and it's like, wow, this is so critical. So I echo Carolyn. Public health literacy has to be integral to any work that's done in the public health field.
Okay, so we have at most 9 minutes left. I do not see any hand raised, but I invite people to show. I see a hand raised.
There are a few
Jane.
questions. There are a few questions that have been posted in the chat.
Yep.
Yeah, so I was looking at the one, has anybody implemented a health literacy champion program at their facility? It's not under that name, but we have a patient education guidance council, and the council is just a little over a year old now. And our goal is to champion and advocate for health literacy policies and change across the organization. We have about 40 people on the council, 40 people on the council representing 25 different service areas, from legal to office of patient experience to surgery to direct, patient care, nursing, research. So we have a broad variety of voices that are coming to the table and having these same discussions internally. And so, yes, we have a championship program. That's what I call it. They are champions. They are excited to be doing this work. And hopefully it will be making a big difference for us in the years to come.
I would like to add to that. One of the things that we did is we have patient education committees in each of our entities. So be it ambulatory, each of the different hospitals, home care group, the payer division, and so forth. And the reason those committees exist, there's administrative functions to it, but there's also the champion component of it. And so we see it, I see it as the importance of the champion side as important as the administrative side. This is where you gather folks that are passionate about patient education, and you continue to nurture that level of passion by providing information and support for the work that they're doing, and more information for them about why this is important, and giving them an opportunity to excel. And by doing that, goes back to one of the original questions we had, is how to sustain the change. When you have a large number of champions, they will then pass that along the organization. But I do think, and going back to the research component of this, how do you develop a toolkit or something like that for creating champions and sustaining change? I think it would be a welcome addition to the work that we do.
Thanks. And reminds me, we did develop a PowerPoint presentation on champions. And I'll see if I can get the, oh, I know it's embedded in interactive training on making informed consent and informed choice. So yes, Carolyn.
I was just going to join in with the champion. Really hard to sustain, really hard. And I feel like I'm being kind of Debbie Downer here. We have several champion groups. It's just very hard to sustain. It's very hard to get it out to where it needs to be. You have your champion, they attend the meetings, they have the information, but then getting it out to the rest of the masses is the next challenge. And I'd really love to know people who are doing that extremely well. And we have diabetes ones, we have infection ones. I mean, we have all kinds of ones, and we're all faced with the same thing. And we do have a patient education group that does represent different disciplines. But I would have to say, I think we have limited effectiveness in how much that goes out to the different departments.
Great. Yes, Karen.
Yeah, I'd like to add with the champions, lessons learned from my organization was to get your marketing and communications team on board with your health literacy work up front. In the beginnings of our work, we had a director of marketing who was a huge champion of health literacy, really understood the importance of it. So she was out there cheerleading. She helped create our website. So having her as a champion really helped. But now to sustain that, when she left, the following marketing person was a little bit more challenging to get on board. And as a matter of fact, we felt a little bit of pushback at times as far as what we were putting out in our communications. So that was a lesson learned from us, getting marketing on board.
Okay, so we are winding down. So I'm going to give you guys a last chance to make a point, reminding you that, you know, this session was on research, how you use it, what would be helpful. Anything that you either want to double down on, or you forgot to mention earlier and would like to say. And I'm being reminded that we have 3 minutes. So this is going to be a lightning round. Who wants to start?
I'll start.
Carolyn, go.
So I would just say that I think all of us would be very interested if we're looking at doing a larger study and would like to involve a lot of institutions that would show us return on investment tied to patient safety quality. Definitely would like to know about it, be involved from the ground up to be able to help mold it, but it'd be great to partner with people to do that.
Thank you. Anyone else want to get a last word?
I would just echo Carolyn's thoughts as well.
Okay, we got a ditto from Tom. Anyone else? Yeah, Karen.
So for me, patient safety link is really critical right now.
Okay. Give us this patient safety impact. Yeah, Greg.
I just want to throw out there a thank you to anyone who chooses to research health literacy, because we're standing on the shoulders of all those who've done it already. So let's do it.
Yes.
Thank you, Greg.
Great, Greg.
I think unless anybody's got to say something, that's a great note to end on. For those of you in the East Coast, it's almost 6 o'clock. and I bet you're ready to pack it in. This has been such a wonderfully full and informative day. I know you're going to want to jump on tomorrow morning, and Michael is going to tell you anything you need to know about that.
No, it was fantastic to hear from you all, and thank you, Cindy, for coordinating that, the moderating. And yes, tomorrow is the next day at HARC, 10:30 on the East Coast, and we'll be hearing from Victor Montori, who's focusing on shared decision making. One of the things that Cindy had said earlier was like, how do you do this at all? Unless people are empowered to like actually participate and know what they want and understand, you know, it's kind of all fundamental to the whole thing. So thank you all. And it's actually quite inspiring to see you. You guys are actually the kind of the lead champions in your organizations. So awesome.
Thank you for taking our research and putting it into action.
Yes, exactly. All right. Be well. See you tomorrow, hopefully.
Thank
Thanks.
you.
Thanks, everybody.
Sure.